Good morning and good afternoon. My name is Tracy Cook and I'm with Sachs Healthcare Communications. Welcome to our webinar today. I would like to show our audience today how to send in your questions, which our speaker will answer as many as possible at the end of the webinar. You can just type your questions into the questions box. You can also download the handout in the handout section of the GoToWebinar control panel. Our moderator for today is Christina Davis. Christina is currently an adjunct professor at the University of the United States in San Diego, California, and Aspen University in Denver, Colorado. Christina has an extensive background in GI digestive disorders in both the treatment and diagnosis of GI and hepatic disorders. Her background includes clinical research through the NIH and FDA on infection-related topics. Christina, welcome.
Good afternoon. Thank you, Tracy, for that very kind introduction. The title of today's presentation is Endoscopic Ultrasound, Batman Returns. Speaking today on this intriguing topic is Dr. Cameron Ayoub. Dr. Ayoub is considered an expert in advanced endoscopy and specializes in all areas of interventional endoscopy. He has performed more than 70,000 procedures, including complex ERCPs, endoscopic resections, and endoscopic anti-reflux procedures. Dr. Ayoub's research interests and focus has been based upon developing new techniques in interventional endoscopy and new technologies for the care of patients with digestive disease. He has a passion for teaching, research, and innovation, especially as it relates to advanced endoscopy. He has published numerous articles and abstracts and written 2 book chapters. He has spoken extensively at national and international meetings and has directed numerous courses, seminars, webinars, and workshops related to advanced endoscopy. Disclosures, consultant for Medtronic. The opinions expressed are the personal opinions of the speaker and do not reflect the opinions or views of the sponsor Medtronic or Sachs Healthcare Communications. This activity has been approved for 1 AMA Category 1 credit. A link to obtain your certificate will be available at the end of the webinar. The accreditation statement is below. This activity has also been approved for 1 contact hour for nurses. A link to obtain your certificate will be available at the end of the webinar. The accreditation statement is below, and support for this activity has been provided by Medtronic. And I would like to turn it over to Dr. Ayoub. Thank you.
Thank you, Christina, for the kind introduction. I'm going to talk about endoscopic ultrasound. Good afternoon, everyone. Good morning, good evening, wherever you're located. Endoscopic ultrasound is a relatively new technology.
Dr. Ayoub, my apologies. Can you put that into full or presentation mode?
Thank you. So the learning objectives of today's presentation are to discuss the clinical utility of endoscopic ultrasound, describe some limitations of endoscopic ultrasound, and discuss newer indications of EUS or endoscopic ultrasound. As many of you are aware, there are 2 main types of endoscopes, echoendoscopes called radial and linear echoendoscope. There is also the mini probes, which are also divided into 2 types. I'll discuss these types first. The radial echoendoscope is the first instrument, became available in early 80s, still the most widely used echoendoscope worldwide. The scanning plane of this scope is perpendicular to the long axis of the scope, such that you are able to take a 360-degree image, much like a CAT scan, but highly magnified. Magnification is so high that we can see lesions millimeter or less. The linear echoendoscope, on the other hand, the scanning plane is parallel to the long axis of the scope, so you can see only in one direction. The advantage is that if the needle was to be introduced, you can see the needle throughout its entire length, whereas with the radial echoendoscope, you'll see the needle as a dot only. Thus, with linear echoendoscope, you are able to perform fine needle aspiration. Here to the left is an example of tumor of esophagus. You can see on the top left radial echoendoscope giving you a 360-degree view, and bottom on the left side you see the linear echoendoscope view. You can see the tumor lengthwise, And you can imagine if a needle was to be introduced, you'll be able to see the needle throughout its length. Here is the view of needle coming out in a linear echoendoscope. Many probes are two types. There is the catheter probe that goes through biopsy channel of an endoscope or colonoscope, mostly used for lesions in the transverse or right colon. Then there is intraductal mini probe that goes over the wire into the bile duct or pancreatic duct. The mini probes, unfortunately, have not taken off big time in the United States. In the southwest suburbs of Chicagoland, I think I am the only one who uses these probes. So not very popular, but in my opinion, it works well in selected cases. Here is a picture of catheter probe to the left, comes out of colonoscope. So if somebody sees a submucosal nodule or lesion in the cecum or transverse colon where we cannot advance the echoendoscope, we use this mini probe. It's also very useful for mucosal-based lesions, looking at Barrett's epithelium for multi-layered epithelium or things like that, wall thickness in patients with different type of lesions. Mini probe, on the other hand, we typically use to look at indeterminate strictures in the bile duct or pancreatic duct, evaluating IPMN if there's a tumor or not, and some similar questions. I would not be discussing the catheter probes anymore during today's presentation. I'll focus on radial and linear endoscopic ultrasound. There are 3 different size needles available in the United States, the 25 gauge, 22 gauge, and 19 gauge needle. The needles used to be fine needle aspiration needle, but now we have biopsy needles as well. The 3 different types commonly used are the ProCore, SharpCore, and Acquire needle. There's also a TrueCort needle available that has gone out of fashion. For those wanting to learn endoscopic ultrasound, I think this is the single most important slide. So people trying to learn endoscopic ultrasound from today's presentation should focus on this slide. The luminal gastrointestinal tract is seen as a 5-layer structure with normal 7.5 megahertz ultrasound or 10 megahertz. The first layer is mucosa, superficial mucosa. It's a bright or hyperechoic layer. The second thin layer, I hope you can see my arrow, just underneath the mucosa is a dark or hypoechoic layer, which is deemed to be deep mucosa or muscularis mucosa. The third layer is bright or hyperechoic and rather thick. This is submucosa. And the fourth layer, deeper to submucosa, is called muscularis propria. It is a hypoechoic layer and it's the main muscle layer of the GI tract. And in select parts of the GI tract, we see serosa as a bright or fifth layer. So this concept is very, very important when we are looking at early tumor staging. We like to see whether it's limited to mucosa only or mucosa and submucosa, which will be T1 lesion, T1M or T1SM for mucosa, submucosa respectively. If it's going into the muscularis propria, it becomes T2. If it's going beyond muscularis propria, then T3. And if it's invading surrounding structures, then it's called T4 lesion. So the T and M classification, the T part, we can do very well with endoscopic ultrasound. Moving on to indications of endoscopic ultrasound, these are the classic indications: staging of gastrointestinal and lung cancer, evaluation of submucosal lesions and extrinsic compression, diagnosis of chronic pancreatitis, localizing neuroendocrine tumor, diagnosis of bile duct stones or other biliary tract disorders, and evaluation of anal sphincter in patients with incontinence. There are interventional indications of EUS, which are rapidly expanding. The classic indications include fine needle aspiration of masses and lymph nodes in and around the GI tract, celiac plexus neurolysis, and some other nerve blocks in the management of chronic pain syndrome, mostly cancer pain, pancreatic cyst evaluation and aspiration, pancreatic cyst treatment. In case of pseudocysts especially, we can do drainage of pseudocysts, and some of the more pre-malignant type cysts, we can treat with absolute alcohol injection or radiofrequency ablation. Some other interventional indications of endoscopic ultrasound include Botox injection in lower esophageal sphincter in patients with achalasia and in patients with refractory anal fissure, fiducial placement for cyberknife treatment of tumors, pancreas, lymph nodes, etc., radiofrequency ablation of pancreatic neuroendocrine tumors or pancreatic cancer, which are small in patients who are deemed not surgical candidates, sometimes also applied for pancreatic cysts. Endoscopic ultrasound guided cholangiopancreatography in patients where ERCP is unsuccessful. Edge or endoscopic ultrasound directed transgastric ERCP, and then endoscopic ultrasound guided gastrojejunostomy. There are some other newer upcoming indications that are not FDA approved yet. Patient preparation is pretty similar to upper or lower endoscopy. So for upper EUS, same as EGD, colon mini probe EUS, same as colonoscopy, and for rectal EUS, typically same as colonoscopy, but sometimes we use Plexic prep. Sedation is really local availability and judgment of the physician. I typically use MAC for most EUS FNA procedures. For high-risk procedures, general anesthesia. In many parts of the world, conscious sedation is used as MAC is not readily available, which is okay as well. So now I'll go over some of the indications and role of EUS in those indications. The classic indication is submucosal nodules or extrinsic compression, typically seen on upper endoscopy, upper GI series, or CT scan revealing some lesion pressing on the stomach wall or some lesion growing on the gastric or esophageal wall. With endoscopic ultrasound, we can differentiate extrinsic compression from a vascular lesion from solid tumor. We can detect whether the lesion arises from mucosa, submucosa, or muscularis propria, and we can diagnose invasion of deeper layers or surrounding structures. We can also look for lymph nodes around the lesion. So here is a classic example of submucosal nodule that most gastroenterologists would have seen during endoscopy. Its mucosal biopsies are always normal. When you do endoscopic ultrasound, you see a submucosal lesion. In this case, it's a hypoechoic or dark lesion. You can see it's contiguous with muscularis propria layer here, or the fourth layer of GI tract, classic for gastrointestinal stromal tumor or tumor of smooth muscle. Stromal tumor being more and more commonly diagnosed with advent of EUS. Here is another similar lesion, but as you can see, this lesion is hyperechoic and is contiguous with the submucosa layer, consistent with the lipoma. This is really a pathognomonic feature for lipoma. No further workup is necessary in this patient, whereas the previous lesion is considered pre-malignant and would require further evaluation, surveillance, or surgery. Here is another example of submucosal nodule referred to me by one of my colleagues. Luckily, did not do biopsy on this one. This was unsuspected gastric varices in a patient with splenic vein thrombosis. Moving on to carcinoma of esophagus, endoscopic ultrasound is established as single best modality for T and N staging. T-stage accuracy in the classic studies is 85 to 95%, end-stage accuracy about 80%. We think there is improved end-stage accuracy with fine needle aspiration. The studies were done prior to fine needle aspiration used commonly for esophageal lymph node staging. It's also useful in diagnosing recurrence of carcinoma esophagus. There are some limitations of endoscopic ultrasound. The M stage can be difficult, especially metastasis to the lungs we cannot see. Liver mets, if they are very far, close to the, away from the gastric lumen, can be harder to see. We can only see 6 to 8 centimeters from the lumen. So the distant mets can be a problem. if there is stenosis or tight stricture of esophagus as a result of malignancy, that can be problematic. Sometimes we cannot pass the scope through because it's a side viewing and relatively large diameter scope. There are over-the-wire probes available that can be used in this setting. Staging after radiation or chemotherapy tends to be inaccurate because endoscopic ultrasound cannot differentiate between inflammation, ulceration, and tumor. Here is an example of T1 tumor. This tumor you can see at about 11 o'clock is going into submucosa, so that will be T1 SM or T1 submucosa tumor. Here you see an example of T2 carcinoma. The tumor at 8 o'clock location is invading muscularis propria layer. Here you see some submucosa between the tumor and the muscularis propria, but in this area, 6 to 8 o'clock, you see the tumor is invading muscularis propria. So this will be T2 carcinoma of the esophagus. And here is an example of T4 carcinoma esophagus. Tumor is invading the aortic valve here, descending aorta. I'll show you a quick video. This patient actually had chemotherapy, and following chemotherapy was sent to me for restaging. Here you see the echoendoscope is just entered the stomach. We normally do esophagus staging during withdrawal more so than going down. Now, if you look carefully, I'll stop the video here. You see the left atrium from 9 to 11 o'clock direction, descending aorta at 5 o'clock, spine is here, and you see a tumor which is almost circumferential. Tumor outer margin is very, very smooth. You don't see tumor pseudopodia going out. This is classic for T2 carcinoma of esophagus. And here, an example of T3 carcinoma. You'll see in a minute the tumor pseudopodia growing through muscularis propria from 6 to 9 o'clock region. Here you see tumor going through muscularis propria. Here, the outer margin is smooth. That would be T2 tumor. But in this area, you see tumor was going through the muscularis propria layer. So that would be a T3 carcinoma of esophagus. So with the advent of endoscopic ultrasound, we have what we call a stage-directed approach. T1 carcinoma of esophagus on EUS, we typically perform endoscopic mucosal resection or ESD, endoscopic submucosal dissection, or in places where EMR, ESD is not available, we send them for surgery. T2 carcinoma requires esophagectomy straight away. A T3 carcinoma of esophagus, we try to downstage the tumor with chemotherapy, followed by surgery if tumor responds. And T4 carcinoma, surgery is contraindicated and hazardous. We do palliative treatment with stents, etc. Prior to EUS, we did not have this type of stage-directed approach, and there were many futile thoracotomies performed, which were hazardous. I will move on to carcinoma stomach, where it is really similar story to carcinoma esophagus, so I'll not spend any time on this slide. The limitations with carcinoma stomach include some issues with overstaging. Many of the gastric cancers tend to ulcerate, and with ulceration, you get at the deep end, you get peritumoral inflammation, which can lead to overstaging. So T2 can look like T3, so we have to be careful. Carcinoma rectum, a similar story to carcinoma of the esophagus. EUS is considered single best modality for loco-regional staging. We can do fine needle aspiration of the lymph nodes as well and detect regress. So much for the luminal cancers of esophagus, stomach, and rectum. I'll move on to pancreatic disease. I think endoscopic ultrasound has played a major role and has become a key player in diagnosis and management of pancreatic disease. There is increasing role in patients with gallstone pancreatitis. If patient has stone in the bile duct, obviously they go for ERCP. But there are many patients which are deemed low to intermediate probability for retained stone in the bile duct. Those patients EUS is extremely helpful. We can see the bile duct stone. If there is a stone, they go for ERCP. If not, ERCP is not performed. Acute idiopathic pancreatitis is defined as pancreatitis in the absence of gallstones, alcohol abuse, or family history. So we call it non-A, non-B, non-C hepatitis, no alcohol, non-biliary, and non-congenital. And those cases, idiopathic pancreatitis constitute about 10% of patients in a hospital, admitted to hospital with pancreatitis. These patients, study by one of my mentors, Laurent Palacios, revealed EUS can determine the etiology in more than 2/3 of patients, 70% of patients. The common etiology they found in this study was small stones or sludge, early chronic pancreatitis that was not appreciated on CT or MRCP, or a small pancreatic tumor. Less than 1 centimeter tumors can be hard to diagnose by other imaging modalities. For chronic pancreatitis, endoscopic ultrasound is deemed very sensitive, and it detects early changes of chronic pancreatitis, including hyperechoic strands or hyperechoic regions, echogenic foci, hyperechoic duct wall, accentuation of lobular pattern, we call it lobularity or honeycombing of the pancreas, and small cysts. Ductal changes include irregular contour and thickened border that shows as a hyperechoic or brightened duct wall, dilated duct, dilated side branches or clubbing of the side branches, pancreatic duct calculi, and strictures. The initial changes are not appreciated on CAT scan, MRI, or MRCP. So endoscopic ultrasound is the only modality that's able to detect the changes of early chronic pancreatitis. And here is a classic example. This patient had MRI, CT scan, $1 million workup, and everything was negative. I performed an endoscopic ultrasound, was referred to me for epigastric pains. And you can see the hyperechoic duct wall. This is the pancreatic duct. It's irregular here. The duct wall is bright or white. This is not normal. Normally, it's almost unappreciable. You can see the hyperechoic foci, these bright spots, and hyperechoic strands. And there is a hint of lobularity here in this area. Here is more advanced chronic pancreatitis that you can see on CAT scan and perhaps on KUB as well, because there is heavy calcification, head of pancreas. You can bile duct stricture. Bile duct is basically constricted and dilated upstream. With carcinoma of the pancreas, endoscopic ultrasound is deemed best modality to obtain tissue diagnosis. T-stage accuracy for staging is 85 to 96%, but luckily the CT scan, especially the helical pancreas protocol CT scan, has very high accuracy as well. End-stage accuracy is 72 to 80%. EUS paradoxically is more accurate in patients with small tumors, less than 2 centimeter tumors, very accurate. However, larger tumors greater than 4 to 5 centimeter, it's less accurate because hard to penetrate for ultrasound through this thick fibrotic tumor, and it can be harder to see invasion, distant aspect in vascular invasion with larger tumors. It's also very sensitive in localizing neuroendocrine tumors of the pancreas. Here is what normal pancreas looks like. You can see to the left of screen would be the neck of pancreas, the genu of pancreatic duct. Here is the body of pancreas, and to the right is the tail of pancreas. So this is neck, body, and tail seen through from the stomach. Head of pancreas and uncinate process we evaluate from the duodenum. And here you see in the tumor in the body of pancreas, about just over 1 centimeter tumor, and you can see it looks very big on EUS image. Here is a larger tumor that is invading both portal vein and common bile duct in the head of pancreas. This is a patient was referred to me with a cystic lesion in the pancreas. And as you can see, this is really a mass with cystic degeneration. So there is necrosis, cystic degeneration in the center, but thick border here. The mass is being measured, and you will see it's about 2 centimeters. Looks huge on EUS, but 20 millimeters. So this was a cystic tumor. Here is another tumor in the tail of pancreas, this one, and you can see the splenic artery and splenic vein. Splenic artery is on top here to the right of screen, splenic vein to the left. And I'm trying to find a space where I can perform fine needle aspiration without puncturing the splenic artery. We were able to do that, and this was found to be a neuroendocrine tumor of the pancreas. And I'll move on in the interest of time. Cystic lesions of the pancreas, EUS, is considered best modality to evaluate and in many cases treat the cystic lesions. We can evaluate the size and location of cyst. We can obtain fluid for analysis, tumor markers, CEA, amylase, and cytology. And in case of pseudocyst, we can drain the pseudocyst in one step with endoscopic ultrasound now. Here you see a large cyst measuring the distance between cyst and gastric lumen. We can evaluate any blood vessels interposed between the cyst and lumen of the stomach or duodenum and then perform cystogastrostomy. Nowadays, we commonly perform cystogastrostomy under EUS guidance, but this was, believe it or not, in 2008, the first study where we performed EUS-guided pseudocyst drainage without use of fluoroscopy. Nowadays, it's become common standard. Most places don't use fluoroscopy. This is the old-fashioned way. Now we use Axios stents to drain the cyst. Hot Axios single-step procedure takes 5 to 10 minutes. Moving on to biliary tree, endoscopic ultrasound is the only modality available for loco-regional staging of ampullary carcinoma. It's also very sensitive and picking up bile duct stones and sludge. In fact, it's the only modality that can see sludge very well in most cases. It is considered more sensitive than diagnostic ERCP in detecting small stones. Here you see a case of ampullary tumor. This one had high-grade dysplasia. On endoscopic ultrasound staging, you can see the tumor is limited to mucosa. You can see the bright layer of submucosa going around the tumor. There is no deeper invasion. And we did endoscopic ampulectomy. It turned out it had high-grade dysplasia, foci of intramucosal carcinoma, but the deep margins were clear. Here is a different patient with ampullary tumor that was referred to me for ampulectomy. You can see the pancreatic duct here, bile duct, and you will see the tumor growing into the bile duct. So in this case, patient required a Whipple because there was tumor invading and growing into the bile duct. This was ampullary carcinoma. And here you can see tumor clearly into the bile duct. The ampulla would be here. So this patient was referred for surgery. Here is a patient with two small stones. This one was about 3 to 4 millimeters, about 6 millimeters. You can see it beautifully on endoscopic ultrasound. And this patient was referred to me with chronic severe bouts of abdominal pain, has had $1 million workup, including MRI, MRCP, CT scan, nothing found. And on EUS, you can see a small stone in the distal bile duct that was missed on MRCP. You can see the pancreatic duct here, bile duct, and stone in the distal duct. Ampulla will be here in this case. I'm going to move on to pain management and burgeoning role of endoscopic ultrasound. Chronic pain, as you know, is probably one of the most common, if not the most common reason for medical evaluation. More than 75% of cancer patients develop pain during the natural history of disease. It is commonly neglected by the medical community. So physicians, gastroenterologists, see the patient with pain and try to find the cause and treat it, but not treat the pain. Pain management, there is a WHO step ladder approach, including pharmacologic therapy, nerve blocks, stimulation, ablation techniques, physical therapy, and psychological techniques. I'm going to skip this slide about pharmacological therapy, except to say that pain perception can be a major issue. There is a huge psychogenic component to pain, especially the pancreatic pain due to chronic pancreatitis. We try our patients on citalopram, fluoxetine, gabapentin, etc., the pain modulators or perception modulators. But neurolytic blocks of sympathetic axis remains the mainstay of treatment that works in a lot of these patients, if not all. I'm going to discuss three different nerve blocks: the celiac plexus, superior hypogastric plexus, and ganglion impart neurolysis. Celiac plexus neurolysis is an old technique first described in 1914 by an anesthesiologist. Current was initially performed by anesthesiologists and pain experts. Interventional radiologists also perform this technique now, more so. EUS guided approach was first described in 1996 by Moritz Versima. It is used for upper abdominal pain due to carcinoma of pancreas, carcinoma stomach, liver mets, etc., and chronic pancreatitis. Any of these causes can cause severe pain, and celiac plexus neurolysis is one modality to treat this pain. Here you see the percutaneous approach. They go using a long needle. This is the posterior approach. There is also an anterior approach described. But EUS guided approach comparatively is very simple. The endoscopic ultrasound probe is in close proximity to the celiac artery takeoff and descending aorta. We do not require fluoroscopy because we can perform color Doppler, and our anterior approach, one of the dreaded risks of the celiac plexus block performed by anesthesiologists, pain experts, is paraplegia. It occurs rarely, but can be dangerous. With anterior approach, EUS guided approach, paraplegia has not been reported. It's extremely unlikely to occur because we are in front of the aorta, not sides or behind. Here you can see the descending aorta. Patient's head will be to the right, feet to the left. You can see the descending aorta. Celiac artery is the first branch of abdominal aorta below the diaphragm. Very easy to see. We can perform Doppler, and then we can perform celiac nerve block by placing a needle right above the celiac artery takeoff very precisely and injecting either absolute alcohol or bupivacaine, depending on malignant or benign type of pain, and Kenalog in patients with chronic pancreatitis. Here you can see the descending aorta, celiac artery takeoff. Needle tip is right here, few millimeters from celiac takeoff, and we are infiltrating the absolute alcohol or bupivacaine, depending on situation. Complications of celiac plexus neurolysis include diarrhea, hypotension, which is orthostatic hypotension. Both are the result of sympathetic block. Some of the more dangerous complications include pneumothorax, lower extremity weakness or paraplegia, renal puncture. All these latter complications are rare, but have never been reported with EUS guided approach, are seen only with the CT guided or biplanar fluoroscopy guided approach. This study from Frank Gress et al. New York was a randomized trial comparing EUS guided versus CT guided celiac plexus block in patients with chronic pancreatitis. EUS provided superior pain relief. EUS provided more durable pain relief, and also EUS guided approach was less costly than CT guided block because the interventional radiologists and pain experts are, I guess, more expensive than gastroenterologists. I'll move on to superior hypogastric plexus neurolysis. So superior hypogastric plexus is located anterior to sacral promontory. It mediates painful visceral stimuli from descending and sigmoid colon, rectum, prostate, bladder, cervix, uterus, and upper vagina. Percutaneous block was described by Professor Pat's group in 1990. The indications of superior hypogastric plexus neurolysis include carcinoma of the sigmoid colon, rectum, prostate, uterus, cervix, etc., with chronic pain, or benign conditions including endometriosis, pelvic inflammatory disease, radiation colitis with chronic pelvic pain that is severe. Percutaneous approach is demonstrated here. As you can see, this is a difficult terrain. The interventional radiologist or pain experts, anesthesiologists, basically walk a needle around L5-S1 vertebral body. They want to get in front of the spine, try to avoid the internal iliac and artery and vein, and go into the midline. This is a very vascular area. Hemorrhage remains a hazard with this approach. So the approach is technically difficult. Once they get there, they inject some contrast to see that they are not in the rectal wall or in the retrorectal space, and then perform block, inject the agent. There are limitations. The approach is technically difficult, requires CT guidance or biplanar fluoroscopy, requires injection of contrast, did not take off very well. So Professor Kanazi's group from Strong Memorial Hospital described an anterior approach where they took a very long 16-inch needle and head it from the anterior abdominal wall straight for sacral promontory. This was under CT guidance. As you can see, they're traversing through many different organs, and in an obese person, it's impossible to get to sacral promontory. Accuracy can be questionable as well because the needle tends to bend as it goes through the abdominal structures. So we described an EUS guided approach, basically using a linear echoendoscope. It's advanced to the iliac vessels, iliac bifurcation. Scope is rotated posteriorly, and under fluoroscopy guidance, we can inject right in front of sacral promontory. Here you see a patient with T3N1 rectal cancer. You can see the tumor pseudopodia going through. This is the muscularis propria layer here, and you can see tumor going through muscularis propria. You see a malignant looking rounded hypoechoic lymph node. Here you see aortic bifurcation beautifully into the common iliac, and then common iliac divides into internal external iliac. This is the area where you rotate the scope posteriorly, and you're right in front of sacral promontory. I use fluoroscopy for this condition, and you can place a needle right in front of sacral promontory and inject the neurolytic agent. Anesthesiologists or interventional radiologists can never get such easy access to promontory. So superior hypogastric plexus neurolysis is an established procedure for ablation of pelvic pain due to a variety of pelvic malignancies. Percutaneous approach is technically difficult. EUS-guided technique is simple, quick, and appears less hazardous. And in patients with rectal cancer, we can perform staging, fine needle aspiration of any lymph nodes, and neurolysis in single setting, thus saving time and money. I'll move on to ganglion impar neurolysis. Ganglion impar is a solitary structure located anterior to sacrococcygeal junction. It has painful visceral stimuli transmitted from rectum, anal canal, lower vagina, vulva, urethra, etc., the perineal structures. Percutaneous block was described by Plancart and Pat's group in 1990. I think he was at MD Anderson at that time. Ganglion impar neurolysis indications include carcinoma of the lower rectum, anal canal, lower vagina, urethra, perineum, etc., all those perineal structures. The approach described by anesthesiology is rather difficult and technically challenging. So they basically take a needle, LP needle, bend it about halfway, 1.5 inches from the tip, and try to go just above the anus, below the sacrococcygeal, below the coccyx, and try to go back upwards. So they use a bent needle approach, but many times they use a double bent needle. So what they're doing is trying to push the needle forward, but get the tip to go backwards. As one of my professors from Baylor used to say, there is no right way of doing a wrong thing. I think this approach is fundamentally mechanically flawed, and the failure rate was high. So we described an EUS-guided approach for ganglion impar neurolysis. This approach is very, very simple. You introduce the linear echoendoscope into the rectum. At the level of prostate, rotate posteriorly, and you're right in front of sacrococcygeal junction, where you perform the block using fluoroscopy guidance. This is a patient with carcinoma of the anal canal. One of my first few cases, you can see the tumor coming out of anal canal. These tumors are rare, but very common to have pain, severe non-remitting pain with these tumors. And here you see my scope in the rectum. The needle tip is right in front of sacrococcygeal junction. The image did not scan very well. I don't know if you can see the sacrococcygeal junction, but very simple to reach there. So ganglion and power neurolysis, I think the traditional technique is difficult, requires a bent needle approach. The EUS guided approach is feasible and simple, and in patients with carcinoma anal canal or distal rectum, we can perform staging, fine needle aspiration, and the nerve block in one single setting. I'll move on to the liver lesions. FNA of liver lesions has taken off in a big way in the last decade or so, but we were big advocates of EUS of the liver from the beginning, from year 2000. This study we published with the surgeons in 2002 in American Journal of Surgery. I feel that EUS FNA is superior to IR guided approach in patients who have smaller lesions, less than 1 centimeter, because CT does not demonstrate those lesions very well. In deep-seated lesions, such that the lesions are closer to stomach or duodenum rather than the skin. In patients with ascites, where liver is mobile, it's much harder for interventional radiologists to target these lesions then. And in patients who have liver mets unknown primary, we can detect primary in the pancreas or ampullary region as well. EUS FNA is also useful in patients who had failed percutaneous biopsy by IR. Here you can see a small lesion in the liver. Looks very big, but it's 5.5 millimeters, if you can see this lesion here. And here is a patient who was referred to me after CT scan of the chest, abdomen, pelvis, had a tumor in the head of pancreas, and I was to do FNA of the tumors, and lo and behold, I see a small lesion in the liver. You can see the lesion very well. My needle tip is there into the lesion. This patient was all set for Whipple procedure with Professor Traverso the next day, but my FNA came back positive, thus avoiding a futile Whipple procedure in this patient. We also were the first to describe EUS-guided core biopsy of the liver for diffuse hepatic disease. This was the first abstract we published, looking at a 19-gauge needle performing suction biopsy of the liver. You can see we got a lot of tissue. This is like almost a segment of liver removed. The pathologists were very happy with the sample. They got good cores. This has become standard now. Most endosonographers perform liver biopsy, core biopsy of liver for diffuse hepatic disease. But in those days, this was not performed at all. Liver biopsy was typically performed by interventional radiologists. Even now, around the world, most places, interventional radiologists perform liver biopsy. However, EUS-guided approach is very simple and feasible. Fiducial placement is another big area for EUS. Patients basically can get cyber knife therapy after fiducial placement. This patient had carcinoma esophagus treated, but this celiac lymph node lit up on PET scan. There was nothing else left lighting up. The radiation oncologist sent the patient to me, and here I'm placing a fiducial. This was a long time ago when we didn't have dedicated needle. This was in 2010. Nowadays we have fiducial needles, and you can see the fiducial placed right there. If you can see fiducial with a shadow, this is just the artifact from the fiducial. So I placed 4 fiducial, anterior, posterior, up and down, and they were able to destroy that area. Here is what the gold fiducial looks like. Here is a needle preloaded with the fiducial, very simple to perform the procedure. And then using cyber knife, they are able to destroy that area without any collateral damage. They're able to target from different angles small dose radiation from different angles so patients don't have any collateral damage. Endoscopic ultrasound guided cholangiopancreatography has now become more and more common. This technique, basically patients where we cannot access the ampulla or cannot cannulate the bile duct used to go for PTBD or percutaneous transhepatic biliary drainage by interventional radiologists. And most centers around the world and around the United States still do that. But centers where EUS expertise is available, we do direct puncture of the bile duct. Sorry, I don't know what happened here. And here you see a patient who has carcinoma of the pancreas. You can see a big tumor here, head of pancreas. I'm performing EUCP in this patient, and here is the bile duct. You can see very well. So tumor of the pancreas causing narrowing of the duodenum, could not reach the ampulla, and we were going to puncture the bile duct. Same patient, you can see I've just punctured the bile duct with a hot Axios stent. I think this was 1 centimeter Axios. There is also an 8 and 6 millimeter available. So I punctured the duct, but I'm in a little bit of problem because the duct is not very dilated, and you want at least 1.5 to 2 centimeter Axios so it deploys inside the bile duct, not between the bile duct and duodenal wall. This puncture was made from the bulb, duodenal bulb, and I'm trying to push gently the Axios tip into the bile duct as I deploy. Once I deploy it again, I want to make sure that the phalanges are in the bile duct. You can see the proximal phalanges here, and then we'll completely deploy the Axios stent from the luminal side. I'll go on to the next slide to show you rest, and here Axios has been fully deployed. You can see both phalanges of the stent, and to the right of screen you see the Axios in the duodenal bulb with the black colored bile coming out. We call it Texas tea in Illinois. Training in endoscopic ultrasound is a problematic area around the world. I understand this is an international webinar. We have some international people as well. There is a shortage of well-trained endosonographer. Even in the United States, there is not a sufficient number of training centers. The learning curve is rather slow. I think it's more difficult technique to learn than ERCP even. Training should start early at fellowship level. Many gastroenterologists try to go for a short weekend course and take up EUS, but typically does not work. So my feeling is that training should start now, at least in the United States, at fellowship level. In those parts of the world where there is a shortage of well-trained gastroenterologists, perhaps they can go for a few-week course, do a few hundred procedures under supervision, and then start training. This is my little daughter. When she was little, started playing with my advanced endoscopy books. So I will close with a brief slide on future of endoscopic ultrasound. As Yogi Berra famously said, the future ain't what it used to be. The classic approach has been cancer staging, looking at lumps and bumps, staging the cancer. Contemporary approach is staging of cancer, tissue diagnosis, and perhaps some areas performing nerve blocks. I think in future, we will also have 3D endoscopic ultrasound. We will be measuring tumor volume. We'll be using endoscopic ultrasound more and more for drug delivery, including chemotherapeutic agents, altered viruses and other agents, nerve blocks, anti-reflux procedures, gastrointestinal anastomosis. We have already started performing gastrojejunostomies in select cases. I think it'll become more and more common, and many other indications, including radiofrequency ablation of tumors, etc. So I think the future of endoscopic ultrasound is bright. So with that slide, I will stop here. Thank you for your attention, and I'll take any questions. I'll turn over to our moderator, Christina. Thank you, Christina.
Thank you, Dr. Ayub, for a very informative presentation. I would like to tell everyone how to get their certificate of completion. Again, this activity has been approved for 1 contact hour, To obtain your CE credits, you're going to go to www.saxtesting.com/INIT. You will need to register at the site, complete the evaluation, and upon successful completion, you'll be able to print your certificate of completion. And the archive or on-demand version will be available on www.patientsafety.org. An email will be sent to everyone when it's available, and the on-demand version will also be accredited for physicians and nurses. And with that, let's get started with some questions. Thank you again for a great presentation. One of our participants would like to know, why do you think mini probes aren't used so frequently? It seems like they would be very beneficial.
So the mini probes are, in my opinion, beneficial in select settings. The main use that I see for a mini probe that I get referrals for is right colon cecum nodules, where I perform mini probe to differentiate cystic lesion from gastrointestinal stromal tumor, for example. I also use mini probe in bile duct and pancreatic duct a lot. That's the intraductal ultrasound. Those probes are expensive. Those are $5,000 to $6,000 a pop. Those probes typically, Olympus says should last 10 uses. My probe lasts 60 to 80 uses because I only let 1 or 2 nurses handle the probe, and I remind them again and again, you can't kink this, can't bend this, because it breaks very easily. With the intraductal ultrasound probe, if you use the elevator with the probe, it breaks immediately as well. So the probes are expensive, about $6,000, and break easily. Does require some extra training, and most centers, because they don't perform the mini probe EUS, do not train in that technology. I find it very useful for some smaller ampullary tumor, lesions of the bile duct, indeterminate strictures, etc.
Okay, so it sounds like expense is a big factor there.
Yes, and the lack of availability as well, not widely available because of the cost.
Got it. Thank you. In your practice, what do you find are the most common indications that you specifically do endoscopic ultrasound for?
So mostly for cancer staging that I do, cancer staging and diagnosis. So staging of carcinoma esophagus, rectal cancer, sometimes stomach cancer, and then fine needle aspiration biopsy for diagnosis of pancreatic carcinoma, looking for lymph nodes, liver lesions, FNA. Those would be the most common that we see in practice, I think, throughout the United States, and that's what I see as well.
Thank you. And someone would like to know, can you review the technique for the EUS approach for superior hypogastric plexus neurolysis?
So the technique, this is basically technique that's not widely available. My group was the first one. We described it in 2001 and never really published it. We presented an abstract, did some oral presentations, wrote a book chapter, forgot to publish it. So that's why I think it never really has taken off in a big way. Some centers perform it. Basically, you introduce the endoscopic ultrasound, linear echoendoscope into the rectum. You can use, I use fluoroscopy. So you can see the spinal canal well, and with fluoroscopy, you rotate the endoscope posteriorly. Once you see sacral promontory on fluoroscopy, you place the needle right in front of promontory. With EUS, you can see the internal and external iliac bifurcation. So the sacral promontory is typically located medial to the iliac bifurcation, close to internal iliac artery. So you see iliac vessels, you can avoid those very well with EUS. Place the needle tip right in front of sacral promontory and inject the agent. Typically, I use it for malignant pain only, where we inject 20 cc of absolute alcohol and 20 cc bupivacaine in front of the sacral promontory for superior hypogastric plexus neurolysis. Cut that amount into half, 10 and 10 for ganglion impaired neurolysis. But that's the technique, very simple. You do need to.
Thank you. Another participant would like to know, do you do a lot of EMR, and what would be your deciding factor on surgery EMR on a tumor?
Well, I do a lot of endoscopic mucosal resection and endoscopic submucosal dissections, ESD and EMR. That's one of my passions. I do it for carcinoma esophagus for T1 lesions limited to mucosa. I also do it for T1B lesion going to submucosa if patient is not a candidate for esophagectomy. Many times when I do ESD for submucosal lesion in carcinoma esophagus, I perform photodynamic therapy afterwards because submucosa classically is not considered amenable to endoscopic resection in the carcinoma esophagus setting. In the cancer of colon, rectum, I do EMR in T1B submucosal invasion as well. And those, if you have a clear margin, are deemed cured, especially if they are well differentiated or moderately differentiated malignancies. Poorly differentiated, obviously, are not deemed curable by EMR, do require surgery and further treatment. But those are the settings where I would perform endoscopic mucosal resection.
Perfect, thank you. It sounds like the EUS guided approach is much better with the ganglion and PAR neurolysis. What is the best way to improve technique when learning this?
So again, it's a very simple technique. You have to find the sacrococcygeal junction on fluoroscopy, ERCP table I use. You go into the rectum, rotate, when you find the prostate, distal rectum, basically rotate the scope posteriorly, and you're typically right in front of sacrococcygeal junction. Under fluoroscopy guidance, place the needle right in front of sacrococcygeal junction and inject. With EUS, you can see that the needle tip is outside the rectal wall. With fluoroscopy, the IR cannot tell whether they are in the rectum or behind the rectum, so they have to inject contrast to see where they are. But we can see it very well, the rectal wall layer. So once you're outside the rectal wall in front of sacrococcygeal junction, it's a small space, very easy to perform ganglion and PAR neurolysis. Again, unfortunately, I described it a long time ago, moved into private practice, never published this technique, and has not taken off. Did write a book chapter, but did not publish it in any of the journals. I think we should now. So we're working on that.
Thank you. And I think we have time for one more question. They would like to know, what advice do you have for new physicians wanting to perform EUS?
So EUS, I think that it requires a lot of passion and knowledge of anatomy, cross-sectional human anatomy, and radiology. If you have good knowledge, if you can read CT scans very well, that will make it so much easier to perform and learn endoscopic ultrasound. So have good knowledge of cross-sectional human anatomy, meaning see more and more CT scans, and then perform EUS. Basically, you need to have good skill of being able to use side-viewing echoendoscope and practice as much as possible. When you start performing EUS, look at every pancreas, every bile duct if you can, all the stations. There is a station-based approach that I teach my fellows. So the duodenum station will be ampulla, gastric station, VUD, we take G junction just below. And in the esophagus, we start with different location, but I take subcarinal region as the station, home base. We call it the home base or main station, station 1, and learn with station-based approach. You do need a good mentor who has a strong knowledge of endoscopic ultrasound.
Perfect. Well, thank you for that advice. And with that, I think we're all done with our questions. So thank you. I'm going to pass it back to Tracy.
Thank you, Christina. And we'd like to thank everyone for attending today's webinar. You will receive a survey immediately upon the conclusion of this webinar. You will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. To get the CE certificate of completion, please visit www.saxtesting.com/INIT and register at the site and complete your evaluation. We'd like to thank everyone for attending today's webinar, and we wish you a very pleasant rest of your day. Thank you.
Thank you very much.